Hey guys, it's Arit, and today we'll be talking about hemostasis and related disorders. Okay, so let's just start. So let's have a quick recap of what hemostasis is. I'm pretty sure we're all familiar with it. We've done this in second year physio. So just quick recap. You have primary hemostasis, which the main aim is to form the platelet plug. Okay, the first step is vasoconstriction, mediated by endothelin. You want to vasoconstrict to decrease the amount, try at least, to reduce the amount of blood flow so that there is less bleeding. The second step is platelet adhesion. And platelet adhere to the subendothelial collagen via von Willebrand factor, as we can see here. And they do this via glycoprotein 1B receptors. Let's see if we can find a picture here. So we can see glycoprotein 1B receptors, von Willebrand factor, and them attaching to the subendothelial collagen. The next is once the platelets adhere to the subendothelial collagen, they degranulate and they release ADP, thromboxane A2. These are the important ones. They release a bunch of stuff, but let's focus on the important thing. ADP promotes glycoprotein 2B3A receptor exposure, and we'll talk about it. And thromboxane A2 promotes aggregation of more platelets so that we can form a better platelet plug. So in step 4, in the platelet aggregation, you have platelet aggregates like they stick together via this same thromboxane 2B3A receptors. So as we can see, as we can see over here, this is the 2B3A receptors on each platelet, and they're linking together through fibrinogen. So the next is secondary hemostasis. In secondary hemostasis, we're trying to stabilize the platelet plug. That's where you have your coagulation cascade, the intrinsic pathway, extrinsic pathway, and so on. So the main thing is that we're trying to form thrombin, fibrinogen on platelet to form fibrin. Now, how the coagulation cascade starts is that you have an extrinsic pathway and an intrinsic pathway. The extrinsic pathway, which is faster, uses tissue thromboplastin. This is the main starter for the extrinsic pathway. And the intrinsic pathway is activated via exposure to subendothelial collagen. Basically, tissue thromboplastin is circulating, and once there is a rupture of the vessel, okay, something that causes bleeding, it leaks out and it activates the extrinsic pathway, which we can see here. So a tissue factor activates platelet factor 7, forms it into activated factor 7, which can activate factor 10 and form it into activated factor 10. And we can see that this pathway is shorter than this pathway. And from here onwards, we're having the common pathway because everything, both in the intrinsic and extrinsic pathway, is for the conversion of factor 10 to activated factor 10 to form thrombin, which will eventually cleave fibrinogen to fibrin, and then you have stabilization of the fibrin to form the fibrin clot. So that's how we're forming the wound healing over here. See this? This is the clot formation and stabilization. Okay, and then the last step is fibrinolysis. Okay, now the disorders of primary hemostasis can be divided into quantitative or qualitative. Okay, so primary hemostasis, like we said before, is formation of the platelet plug, which means that anything that has to do with primary hemostasis is a disorder of the platelets. We're not talking about the coagulation cascade. We're not talking about any of the factors. We're only talking about the platelets. Okay? Now, if you have a problem with clotting blood, if you have a problem with forming a platelet plug, what is the symptom you're going to have? If you cannot stop the bleeding, the main symptom is bleeding. So the symptoms we have here are mucosal bleedings like epistaxis, which is bleeding from the nose, hemoptysis, which is coughing up of blood, GIT bleeding, hematuria, and so on. Skin bleeding, we can see petechiae, which is over here. We can see ecchymosis, which is a bigger, over here. We can see purpura formations, which are just basically just bleeding under the skin. And I want to mention a side note here. Petechiae is usually a sign of thrombocytopenia. Ooh, this is spelled wrong. But and it wouldn't be seen in qualitative disorders, which we'll talk about later. So thrombocytopenia meaning that there's a low amount of platelets. Okay, so this is the normal platelet count. Okay, so if you have less than this, you have thrombocytopenia. Now, how do we measure? How do we know that a person has problem with primary hemostasis? First of all, there's low platelet count, bleeding time. I'm sure we also did this in second year physio. You can prick skin. I think what we did was the earlobe and see how long it takes for the bleeding to stop. Okay. So normally it should take about 2 to 7 minutes. But if you have a problem with your platelets, both qualitative and quantitative, you would have a prolonged bleeding time. And then in other cases, you can also do a bone marrow biopsy to measure the megakaryocytes because you know that that's how platelets are formed from megakaryocytes. Next. So the disorders of primary hemostasis, quantitative. First of all, we have immune thrombocytopenic purpura. So this is an autoimmune IgG production against platelet antigens. So this and all these disorders are not very frequent. Okay, so we have an autoimmune IgG production against platelet antigens, and this is more common in children and young adults. Okay, so we have autoantibodies that are produced by plasma cells in the spleen. Now, these autoantibodies, they bind to this platelet antigens and they form this antibody-antigen complex, and then they're consumed by the macrophages in the spleen. And you're having all of this adhesion aggregates that are now consumed by the spleen and causes low platelet count. So you have thrombocytopenia. So acute is usually in children after viral infections or immunization, and is usually self-limiting. And in adults, like I said, autoimmune, it's usually in women. And I just want to point this out as a side note. Usually, when you see something that is autoimmune, start thinking of young women. That should be, even if it's SLE, just most things, Hashimoto's thyroiditis, this is just apart from the case. We're not talking about just mainly hemostasis now. We're talking about generally, if you see autoimmune, your first guess should be thinking the age range is young women. So the treatment of this is corticosteroids, which is the main treatment for any main autoimmune diseases, and then a splenectomy, shrimp cases, so that you're removing the site and the source of destruction for the site of production and the site of destruction for the platelets and the autoantibodies. Next is microangiopathic hemolytic anemia. So this is a long name. Basically, this is a formation of platelet microthrombi in the vessels. Okay, so there's some kind of pathologic condition where there's formation of just small microthrombi, and this is consuming the platelets. So instead of the platelets to be used more effectively somewhere else, you're just having these microthrombi that are being formed here and there, and they're consuming all the platelets. And when you actually need the platelets, they're already consumed. So the two types, we have thrombotic thrombocytopenic purpura, and this is because of a decreased ADAMTS13. This enzyme normally cleaves von Willebrand factor, okay? But now you're not cleaving the von Willebrand factor and you're having platelets adhere to the subendothelial collagen and having a microthrombi formation. and is most common in adult females. Next, you have hemolytic uremic syndrome, and I think you probably saw this in the lecture on E. coli, how E. coli can cause this. Basically, the endotoxin from the E. coli, it damages the endothelial cells, and there is now microthrombi formation. And what is special about this specific case is that when you have these microthrombi formation, they're formed in the vessels, okay? So red blood cells in blood that are passing through can be, can be shared, can be ruptured, can be cleaved by these microthrombi formation, and you see fragments of red blood cells, and these are what is called schistocytes. Okay, and then you can see fever, for example, in a person with E. coli, because this is the bacterial infection. You can see fever. You can also have renal insufficiency, and this is more common in TTP. So these microthrombi occlude the vessels of the kidney. Can also have CNS abnormalities, the same reason thrombi in the vessels of the CNS. And what we want to do here is plasmapheresis. So we want to, how to explain, bring and take out the blood from the person and sieve it, filter it, and put back the correct amount of blood so that you don't have any of these microthrombi that are formed in the blood that is returning back to the patient. And another treatment is corticosteroids, especially with people with TTP. So the lab findings here is that you see a decreased platelet count for obvious reasons, like we just said here, but there will be normal PT and PTT. So this is prothrombin time and partial thrombin time. Okay, and the reason why these are normal is because this has nothing to do with the coagulation cascade. This is only dealing with platelet count, and the coagulation cascade deals with, and PT and PTT deal with the coagulation cascade. So there will be normal PT and PTT. There's increased megakaryocytes in the bone marrow biopsy because now that the platelets are being rapidly consumed, you have to have the body is now signaling more megakaryocytes formation so that they can supply the needs of the more platelets. Okay, now moving on to qualitative disorders. So this is now no longer a problem with the amount of platelets. We're talking about the adhesion of the platelets, the morphology of the platelets, everything to do with that, just not dealing with the quantity, the number of the platelets. So Bernard-Soulier syndrome. So this is a genetic glycoprotein 1b deficiency. And remember glycoprotein 1b, it is used for to attach the platelets to the subendothelial collagen via von Willebrand factor. So there's impaired platelet adhesion. So on blood smear, we would see enlarged platelets. You also have Glasman thromboasthenia, and this is due to genetic glycoprotein 2b and 3a deficiency. Again, platelet aggregation is impaired because, like we said, it's used to aggregate platelets via fibrinogen. Aspirin. Aspirin, this is acetylsalicylic acid, irreversibly inactivates COX. So you can see this pathway here, how prostaglandins are formed using from arachidonic acid, the first step from phospholipids, sorry, you have arachidonic acid here, and then via COX-1 and COX-2, they are formed into the prostacyclins. So if aspirin irreversibly binds this and inactivates it, then you don't have any thromboxane A2 anymore. That's unfortunate. And uremia also impairs both adhesion and aggregation. The exact pathophysiology of how it does this is not quite clear, but honestly, you don't even need to remember it. You can just know that uremia impairs adhesion and aggregation of platelets. Okay, disorders of secondary hemostasis. Now, this is where we deal with the coagulation cascade, the factor abnormalities. The main feature, hold on. The main feature is that we have deep tissue. Oh, this is supposed to say bleeding. Deep tissue bleeding into the muscles and the joint, and rebleeding after surgical procedures like wisdom tooth extractions and so on and so forth. So basically, bleeding. That's the main thing, bleeding. So the common labs that are done here is prothrombin time and partial thromboplastin time. This is supposed to say partial thromboplastin time. Excuse me. So prothrombin time measures the extrinsic pathway, the extrinsic and common pathway. I mean, both of them measure the common pathway, but the extrinsic and common pathway. So it's measuring factor 7, factor 2, factor 5, factor 10 fibrinogen. Okay. Factor 2 is thrombin, for those who don't know. Then partial thromboplastin time measures the intrinsic pathway. Okay, so just think about it. The shorter name measures the shorter pathway. The longer name measures the longer pathway. So, you know what? Okay, disorders of secondary hemostasis. The main ones that we have here is hemophilia A and hemophilia B. Okay, hemophilia A, both of them are X-linked recessive diseases. So hemophilia A is deficiency of factor 8. The main thing we have here is that the lab findings, we have increased PTT. Why? Because factor 8 is part of the intrinsic pathway. Okay, increased PTT for normal PT. Okay, then we have normal platelets and bleeding time because the platelets are fine, but then you have decrease of factor 8 as you would expect. And then for hemophilia B, also known as Christmas disease, it's also X-linked and it's a factor 9 deficiency. So the same thing going on, it's just different factors that are that there is deficiency. So general symptoms is deep tissue bleeding, joint bleeding, and bleeding post-surgically. Okay, so you can see here, hemophilia A and B, factor 8 and 9. So you can also look at the general symptoms here. These are quite non-specific symptoms, so you can just look at this over here. But the main thing is still bleeding. Okay, next. Disorders of secondary hemostasis. Still, the next one is von Willebrand disease. This is the most common inherited coagulation disorder. So remember it. Remember von Willebrand disease. Okay, there are multiple subtypes. We don't have to get into that now. The basics of what you need to know is that this is a deficiency of von Willebrand factor. Okay, so the most common type is the autosomal dominant type with decreased levels of von Willebrand factor. So what happens here is that there is increased PTT. Normal PT, there's a decreased factor 8 half-life because normally von Willebrand factor will stabilize factor 8. Okay, and we're still thinking of the intrinsic pathway. So that's why there's an increased PTT but a normal PT. Same, but in these cases, for some reason, there is no deep tissue bleeding, joint and post-surgical bleeding. This is typically not really seen here. You also have abnormal ristocetin test. So now this test, basically ristocetin induces platelet agglutination because it allows von Willebrand factor, this is supposed to be space, von Willebrand factor to bind to glycoprotein 1b. So if there is a lack of von Willebrand factor, you have impaired agglutination, so there is an abnormal test, okay? The treatment of this is desmopressin, which is an ADH analog. Remember, ADH is released from the hypophysis. Increases von Willebrand release from these bodies of the endothelial cells. I'm not even going to try to pronounce it. Weber Pallade bodies. So anyway, you just need to remember it's the most common type. There is increased PTT, but normal PT, and then the abnormal ristoceptin test. Treatments via desmopressin. Okay. Another disorder of secondary hemostasis is vitamin K deficiency. And this is an interesting one because vitamin K, okay, activated vitamin K, it carboxylates. I'm sure you heard of this in biochem. It carboxylates factors 2, 7, 9, and 10, protein C and also protein S. So it's necessary for coagulation to occur. Vitamin K is a very, 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 very important cofactor. And it's synthesized in plants and bacteria, in plants so you can eat it, but mainly by bacteria in the gut. So this is the thing to keep in mind, mainly by bacteria in the gut. So obviously in newborns, there is decreased bacteria in the gut because there is lack of GI colonization. So they normally don't have enough vitamin K, so they are given prophylactically. And if you are a long-term antibiotic user, if you use antibiotics for so long, then you just disrupt your normal GI flora, which means you disrupt also the normal vitamin K producing bacteria. And then you have malabsorption. So if you have, for example, chronic pancreatitis or acute pancreatitis, and you're not able to digest or absorb, or if you have malabsorption due to like Crohn's disease or something, anything that's just not going to enable you to absorb the fat soluble vitamins, of which vitamin K is part of. You know, fat soluble is ADEK. So if you're not able to absorb this, then you could have a bleeding disorder. Another thing is liver failure, because why? The coagulation factors are proteins and they are produced by the liver. And also, the activation of vitamin K is also done in the liver. Honestly, if you have liver failure, you are very prone to bleeding disorders. And another thing to keep in mind is that when liver failure occurs, you usually start first with an a procoagulative phase first before the decreased coagulation. And then if you have large volume transfusion, it dilutes the coagulation factors and you have relative deficiency. So if you have large volume transfusion, for example, after a massive car accident and you just need so much blood, then this could occur. So another disorder that we have here is heparin-induced thrombocytopenia. So this is when platelet destruction arises secondary to heparin therapy. Okay, so we can see here. Let's see how this situation occurs. So this is life-threatening states of hypercoagulability. So onset about 5 to 10 days after heparin exposure. So you have platelet factor 4. This is released from activated platelets. Okay, here. The heparin binds to platelet factor 4. It has a high affinity for platelet factor 4. And then you have these IgG antibodies that come and bind and form an immune complex with the Fc receptor of the platelets, and it causes abnormal platelet activation and aggregation, and then you just have thrombosis And like I said, remember what I said, that when you have excess thrombosis, you're using up all your platelets and it's causing thrombocytopenia. So the next is disseminated intravascular coagulation. This is so important. This is something you see come up very often. So just remember it, DIC. This is pathologic activation of the coagulation cascade. So now in this case, there's widespread microthrombi formation, okay, that can result in ischemia and infarctions. Why? Because this microthrombi could occlude vessels and cause ischemia or infarction, okay? Another thing that is going on here is its consumption of platelets and factors. So it's also called consumptive coagulopathy, okay? Where, like I said before, you're using up all your platelets and your factors, so it results in bleeding. So, and it's not a standalone disease. It is secondary to something else. So it's secondary to another disease. It could be which is most common, obstetric complication. So in the amniotic fluid, you have tissue thromboplastin. And what does tissue thromboplastin activate? Factor 8 for the extrinsic pathway. So if you have some kind of complication during delivery, it could lead to this causing widespread coagulation. Sepsis, for example, E. coli. We already said it. The endotoxin activates the endotoxin induces the endothelial cells to make tissue factor. It also damages the endothelium, and there is widespread coagulation and microthrombi formation. Also, adenocarcinomas, the mucin activates coagulation. It could be from a snake bite and so on and so forth. So what happens? The obvious thing, decreased platelet factors. Why? Because of consumption. Increase PT or PTT, it doesn't matter because you're using up both the platelet and the factor. So whether intrinsic, extrinsic, doesn't matter. PT and PTT are both increased. Decrease fibrinogen, obvious reasons. Like we mentioned before, the microangiopathic hemolytic anemia. This is when we talked about E. coli before. And then another thing that's important for diagnosis is we see increase in D dimer. D-dimer increase is not a specific, it's not a specific diagnostic factor, but it can lead you to see that there's some kind of like thrombi, some kind of fibrin formation that's going on in the body. So we see elevated the fibrin split factors, which is the D-dimers. So elevated D-dimer is the best screening test for DIC, yes. Okay, now treatments involves addressing the underlying cause. You can transfuse blood products and cryoprecipitates that contain the clotting factors that are necessary. So you can have disorders of fibrinolysis. So like we said before, you have the platelets formed, you have stabilization of the platelets via the clotting factors. Now, when the wound finally heals, the endothelium finally repairs itself, we do not still want that thrombus. We still don't want that plug. So we have fibrinolysis that is going to clear it out. And the main thing here is conversion of plasminogen to plasmin. Plasmin, important. This is the only thing that can cleave the stabilized fibrin, and it's done via tissue plasminogen activator, so TPA for short, so everyone says. So plasmin cleaves the fibrin and serum fibrinogen and destroys the coagulation factors, blocks the platelet aggregation. Everything you need to do here for the fibrinolysis is done through plasmin. Okay, then you have alpha 2 antiplasmin, which inactivates the plasmin because we don't want to go on a plasmin rampage, because as you can see, it also destroys the coagulation factors. Okay, so when you have a plasmin overactivity, for example, in radical prostatectomy, it releases urokinase, and urokinase is also another thing that activates plasmin. Also, in cirrhosis of the liver, like liver is the main place for all of these proteins formation, both the coagulation and the anticoagulation proteins. So if you have cirrhosis of the liver, you have reduced production of alpha 2 antiplasmin, which means that you have plasmin overactivity, and it results in increased bleeding. Okay, and it resembles like DIC. So what happens here is that you have increased PT and PTT. Why? Because the plasmin destroys the coagulation factors. Okay, increased bleeding time with normal platelet count. Why? Because plasmin blocks platelet aggregation. So all of these point back to why there is bleeding, but there is normal platelet count because there's nothing wrong with the platelets. They are just not aggregating to form the platelet plug. Okay. Okay. The treatment of this is aminocaproic acid, which blocks activation of plasminogen. Don't need to remember that, but just to point it out. Another situation, another related disorder to coagulation is thrombosis. Okay, this is the formation of intravascular blood clots. Very common, and it is so common. It causes just a whole lot of things. You can't pinpoint it to one. Infarction, strokes, renal infarction. Okay, myocardial infarction, renal infarction, just pulmonary embolisms, but from emboli, not thrombi. Anyway, the most common location is in the deep veins of the leg. DVT, very important. Just keep that in your mind. You will hear this very frequently. Deep vein thrombosis, usually in the lower leg below the knee. Okay, so this is a person with thrombus formation in the leg, mainly because of you can see the main three factors here: disruption of blood flow, endothelial cell damage, and a hypercoagulable state. So virtuous triad. You can also see this. This is might be important for pathoanat. Lines of Zahn. These are alternating layers of platelet, fibrin, and RBCs, and they an attachment to the vessel wall. So this distinguishes thrombus from post-mortem clot formation, which is something significant in post-mortem findings. You see clot formation, so you want to know if, for example, if someone died of a myocardial infarction, you want to know if this clot was the reason that the person died, or was this, which means it happened ante-mortem, or was this clot just formed post-mortem, you know? So we want to be able to tell the difference between the two because it's important. Anyway, so thrombosis, like I said before, the three main reasons: disruption of blood flow, endothelial cell damage, and hypercoagulable states. So the first one is that normally blood flow is supposed to be dynamic. You're supposed to have just free flow. But if you have a situation where you have stasis of the blood, or if it's turbulent, which can damage the vessels, you will have formation of clots. So, for example, people who have a sedentary lifestyle, they're always sitting, hardly ever standing up and moving, they're at risk of forming deep vein thrombosis. Okay, so immobilization is a main thing. And cardiac wall dysfunction, arrhythmias, especially atrial fibrillation. Very, 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 very important. The main complication of atrial fibrillation is emboli. So thrombus formation that can embolize to another part of the body. Very, 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 very important. Aneurysm, because you're creating a pocket here, which is very prone to thrombus formation. Now, if you have endothelial damage, you understand why thrombus can form, because you're exposing the blood to subendothelial collagen and the underlying tissue factor. So, um, so you're increasing the coagulable state of the person. So damage to endothelial wall could be due to atherosclerosis, vasculitis, high levels of homocysteine, and so on. You can read this whole thing. None of it is super important, just as long as you're getting the general idea that endothelial cell damage can lead to thrombus formation. Hypercoagulable state. This is a situation where there's excess procoagulant proteins or there's a defective anticoagulant proteins. So you could see repeated DVTs or DVTs at a young age should point that there's some kind of underlying problem here. So one, if there's protein C and protein S deficiency, and remember what protein C and protein S are for, they're supposed to inactivate factor 5 and factor 8. Okay? So if you have this deficiency, you're at risk of being in a hypercoagulable state. Okay? When you start warfarin therapy, there's a temporary deficiency of protein C and S. You know what warfarin is for? Warfarin is supposed to prevent clot formation. You're trying to be in an low coagulable state. Okay, this is for people with high risk of forming thrombus formation. So they use warfarin. In the initial stages of warfarin use, because warfarin blocks vitamin K and factors 2, 7, 9, and 10, and protein C and S are activated via vitamin K. In the beginning, you have deficiency of protein C and S in the beginning. So you are in a hypercoagulable state in the beginning. That is why usually when people use warfarin therapy, initially they start using warfarin therapy plus heparin. Okay, so they use warfarin plus heparin in the beginning and then gradually wean off heparin and continue using warfarin just because of this situation. Okay, you can also have factor 5 laden. This is also very common, where you have a mutated factor 5 that cannot be deactivated by protein C and S. So this is the most common inherited state of hypercoagulability, factor 5 laden. Okay, so you can also have antithrombin 3 deficiency, oral contraceptives. This is very important to know, especially if you have a young woman that is coming in. You want to ask her if she's on oral contraceptives, because the estrogen increases the production of coagulation factors, so increases your risk of thrombosis. Now, embolism. Embolism is an intravascular mass that happens when a thrombus dislodges, okay? So you have a thrombus here, blood clot, and then when it dislodges, you form an embolus, okay? So the main reason for and it doesn't also only have to be a thrombus. Like I said here, the first one you could have a thrombus. You can also have an atherosclerotic embolus, which is formed from an atherosclerotic plaque, and that dislodges. Okay, you can also have a fat embolus. This is most probably due to fractures of long bones. You can have, these are the main two are thromboembolic and atherosclerotic embolus. Fat embolus is not that common. The same with gas embolus. In Cason's disease, for example, if you rapidly ascend from going scuba diving, you have nitrogen gas that precipitates in your blood. So the main thing to do is that you have to ascend slowly. Amniotic fluid embolus. that enters the maternal circulation during labor and delivery. And what did we say that amniotic fluid contains? Tissue factor 3. So this can cause DIC. Pulmonary embolism is very important to remember when you're talking about hypercoagulable state. When you have a DVT, you have, if it finally embolizes, it goes through the leg veins all the way to the inferior vena cava, goes into the right atrium, to the right ventricle, and it goes into the pulmonary vessels, to the pulmonary artery. So depending on the size of the embolus, depends on where the embolus will lodge. So if it's a larger embolus, it can even stop here. If it's larger, it can cross here. And the smaller it gets, the lower it gets in the bronchial artery tree. So patients present with shortness of breath, hemoptysis, pleuritic chest pain, and pleural effusion. So in a VQ scan, you see there's a mismatch because perfusion is abnormal, because these places that the embolus is they're still receiving oxygen from the alveoli, but then they are not being, like, the blood isn't being perfused because it is blocked. The blood isn't being perfused because it is blocked by the thrombus. We see increased D-dimer, and then you can have sudden death if there's a large saddle embolus. So saddle embolus is when the embolus is located here. Okay, if it blocks both the left and right pulmonary artery. You can have pulmonary hypertension that arises over time, because what happens when there is blockage of these arteries, you can see increased pressure that arises in the pulmonary system, and that could cause pulmonary hypertension. Could also have systemic embolism if the thrombus arises mainly due to the left heart, especially when you have atrial fibrillation, like I mentioned before. So it can dislodge and block anywhere, especially to the brain, causing ischemic stroke. And you can see all these places. And that is everything. So that's everything. If you have any questions, you can always contact me. A lot of these things are gotten from Pathoma. They're just more explained. So that's everything. Good luck in your exams.